The strengths of the program when I was there is that it was a place that delivered the expertise and care of a major medical center, but in almost a private practice kind of setting. So patient care was always paramount. Even though research and other activities were going on, the patient care was the central focus. They had one rotation that was called the hospital resident, and you had to take care of all of the things that came up in the hospital. You were sort of on call all the time, and that was a little challenging, but it was at the same time rewarding. You got a lot of experience, and there were other times that Dr. Langston and many of the other faculty were more than happy to come over and help me when I was doing that particular clinic. Part of that hospital resident time, we had to run a general clinic for Cleveland Clinic employees. Mm-hmm. So I learned at the Cleveland Clinic the value in having other people in my field who are more trained in the area that they specialize in, consulted early whenever I find that there's any question in my mind that something is a little equivocal or could be better defined, or maybe I could get a better idea from someone else. So in my practice, I started with a partner who's a cornea specialist, and I'm a subspecialty trained glaucoma specialist. We're both anterior segment surgeons and cataract surgeons as well. We have another cornea specialist. We have a retina specialist. And we have a plastic surgeon specialist, and we're soon to have another glaucoma specialist. We also employ optometrists. At the Cleveland Clinic, when I was there, we had an optometrist also to help us with the more intricate refractive things. And we've done the same thing here. Back then, most of the services as subspecialists had journal clubs. So they would have you over and you'd review articles in their specialty in their homes. They'd provide us dinners, and it was very informal but very informative as well. At the Cleveland Clinic, we always had a technician who would do the initial part of the evaluation, and then we as residents would then go in and finish the evaluation. And I pretty much have established the same thing here in my practice. You know, back then you always thought you could it would be nice to be able to do more surgery. Mm-hmm. But I think we had an adequate amount, and we were so well supervised. When we were in medical school, they would talk to us about time with our family and how quality was as important as quantity, or more so, because you weren't going to get a lot of time. And so even with surgery, I think most residents always think that the quantity is the most important thing, but there's a quality side to it as well. And so I think we had a good mixture of both.